Well, good afternoon, ladies and gentlemen. Welcome to Health, High Tech, High Touch. I'm Hee-kyung Kim, reporter and anchor, deputy head of the International News Department at MBN. It's the broadcasting division of Megyoung Media Group based in Seoul, Korea. I'm thrilled to be here to be talking about one of the most important, actually, issues of our time, especially with such a distinguished panel of speakers, and you, the wonderful audience that I know you'll be. We all know that health is a main priority for happiness and well-being, but we also know that for too many people, it's too difficult to obtain a healthy lifestyle under financial circumstances, less access to better education, etc. Furthermore, in many cases, patients seeking care are unsure as to whether they'll be receiving the care that they need and want, and this is especially true for those in high-need conditions that express low confidence in the care that they are currently receiving. I think the main reason is that too many health professionals still tend to provide the care that they think they need without proper explanation or a consultation. So I think we need to better understand what makes the difference in people's healthcare experiences and also outcomes. Well, in the past, we know that cure or the absence of an uncomfortable symptom plus survival rates were the main measurements for care success. But we know that there's much more to that from the patient's perspective. We need the core values of dignity, compassion, and respect. I'm talking about a more person-centered approach, which has become a major topic of discussion in the healthcare realm and was discussed at the OECD forum last year. So one major challenge in realizing person-centered care is transforming the health systems that are unable to cope with the change in patients' needs. To talk about these challenging issues, we have an excellent panel of speakers seated next to myself. First, I'd like to introduce Mr. Nick Clegg, former Deputy Prime Minister of the UK and former leader of the Liberal Democrats. He was Member of Parliament for 12 years and is currently Chairman of the Advisory Board at SERA. Is that correct? A technology-enabled home care provider known for using artificial intelligence in users' health care. Very nice to have you with us, Nick. Also, Len Greer, President of Health and Wellness Solutions at Johnson & Johnson. He's to my right, of course. Thank you for joining us. He leads the company center in charge of behavioral science capabilities, behavior modification, digital patient consumer engagement, coaching tools, and outcomes measurement. Thank you for joining us. Mark Henderson is here. He's Director of Communications at Wellcome Trust, the world's second highest spending charitable foundation and member of the executive leadership team. Prior to joining Wellcome Trust, he was a science editor of The Times, a fellow journalist. Welcome. And Cecilia Rodriguez. Cecilia is a social communicator with studies in public health. After being diagnosed with a chronic condition herself, she has advocated for patients, founded the Patient School, a strategy implemented at the public health system for self-management programs. She's also currently the executive director of Fundación Me Muevo. Welcome. And of course, seated in the front row is Francesca Colombo of the OECD. She will share with us her thoughts toward the end of the discussion. I think she'll be sort of watching over us, and she'll share with us her thoughts. But of course, as I told you earlier, you're welcome to join in during the discussion also. In order to make this session as productive and interactive as possible, we'll be taking questions from the floor. So please do not hesitate to join in. I believe you can use this fascinating technology called Bcast. It's an application that enables the audience to be a part of the conversation in real time, whether you're here physically or joining us online. So you can raise questions at any time during the session, and our Bcast moderator will help me apply these questions and reflect comments into our discussion. Before we begin, we would like to ask you a question that would sort of set the scene for today's discussion. If we can have the question on the screen, would that be possible? Okay, maybe whenever you're ready. Okay, when you have been treated in a hospital or other health service, did you find that the experience was designed for the healthcare provider, the hospital or doctor's office, the supporting technology system, the payer, or you, the patient? I think this is an important question, and if you can answer I don't know, we can show the answers on the poll or on the screen, and I will share with them. Okay. Do we have anybody in the back that will help me put the answers or the questions on the screen for me? Okay, maybe we'll need some time to prepare. Okay. All right. First, I'd like to my question for Cecilia. I mean, you heard me ask about this basic question that all patients or caregivers have been asking themselves for a quite long time, and you have personal experience in this area. Would you like to answer yourself?
Yes, I would like to share a concept that I found once in a book that it's called Through the Patient's Eyes. When I was dealing, like the first year of being diagnosed with rheumatoid arthritis, I was struggling with the illness. It was hard to get out of bed. I spent a lot of time in bed, so I read a lot. So I had this book in my hands called Through the Patient's Eyes. It has been quite a lot of years that it has been written, but we are still dealing with the same things that that book said. And I felt really compelled, like what I was thinking in bed was not something that I was only going through, but it was something that patients throughout the world were going through. And I saw there this term that it's subjective experience of illness. And it just makes so much sense to me. Because living with a chronic condition is, for example, in the case of rheumatoid arthritis, it's not about joints being swollen or walking being difficult or bottles being hard to open, but it's about your life and questions about your life that changes, your perspective of life, what you want, what you believe, everything changes and everything starts to like building, fall apart, and you need to rebuild it, understanding what your condition is. So it's so much deeper, and what I found in this book, that's why what I was feeling in that moment is that the health system is prepared to treat the disease. I had great rheumatologists, good medication. The disease could be under control, but the subjective experience of illness was not being addressed by anybody. Because nobody understands what that means. And little people and little institutions, or few institutions, ask patients what they are experiencing. Not what hurts, not what problem in your body, but what are the issues that you are coping with in your daily life that are much more profound than the disease itself. So that's one issue. And also, the system is not even thought for the patient to be easy to have this condition. Like you need to go for prescription to different places. The Center for Rheumatic Disease is on the -1 floor, and you need to go through a big, how do you call it? Escalator, no? Escalator. And I'm like, I can move. Why they put it on the -1? Not even those little things are thought from the patient. Because what we think is that the system is designed by people that think for the patients, but that don't think and work with patients. So that's a big difference that it has been many years. The book was written in the 90s. We are in 2018, and we are still talking about the same topics. Why can we not address the subjective experience of illness in so many years? What's missing?
I think you raised an excellent point in that there's actually not enough research being done to treat patients with especially multiple conditions. And this is directly linked to, like Cecilia said, to a lifestyle and your socioeconomic status. Mark, would you like to add to that?
Sure. So I'm Mark Henderson. I'm from the Wellcome Trust. We're major global foundation, second largest in the world. We are dedicated to improving health, and the particular means that we apply to that is research and all the disciplines allied to that. And so my role on the panel really today, I think, is to bring the research dimension into this question, because research has to be an integral part of what we do as we construct health systems. It's not an optional extra. It's how we learn to, it's how we drive innovation, how we learn to do things better. And I think you're right, and as Cecilia's experience, I think, very much bears out, far too seldom is actually the patient experience or the person living with illnesses experience, to have perhaps put it rather better, because we aren't all patients all the time. We're patients at certain times in our lives, but we may be living with a condition at many times where we're not. We don't put people living with illnesses at the heart of research questions in the way that perhaps we ought to. I think there are a few different ways that you can take this challenge on. The first one is, as you've just suggested, we do need to think harder about people who have more than one condition, particularly more than one chronic condition at once, which is really common. And people who have comorbidities, more than one condition at once, take up a disproportionate amount of health systems time. And we treat them as if they had multiple sequential instances of one condition. If somebody has diabetes and depression, they're packaged off to see an endocrinologist and they're packaged off to see a psychiatrist in different centers, picking up their medications, often, you were saying in the green room before, from completely different places. And their experience is just of being sick, and we need to research rather better how diseases actually manifest together and what impact that has on how they may be treated. This is something that Wellcome has made a priority in our population health strand, so as to look harder at that question. So that's one thing. I think another issue is that it's related, is that, again, when we do science, when we do research, the classic way we do it is to break it down into all of its components. We try to build a rat model of depression. There's no such thing as a rat model of depression. We try to control all the variables that we can control. This is a perfectly good way of doing science, but it doesn't translate desperately well automatically then into how these things actually impact, how these interventions actually impact on patient lives. One of the things we're trying to do, particularly in mental health at the moment, is to reverse that process, to try to start the research questions with the patient experience rather than with the reductionist animal model, and to work back to the basic science from there. Now, you do still have to do the basic science, there's no question about that, but you can often do better basic science, I think, if you start from the patient experience than if you start from the reductionist system. Another factor in that is actively involving patients in research, in the questions that get asked, and very often when you do that, you get some surprising results. Arthritis is actually a great example. In the UK, you may be aware of this. The main UK arthritis research body took the step, which is quite radical for a lot of research charities, a couple of years ago, of really asking patients with arthritis, what is the research you want us to concentrate on? And they got two very surprising outcomes. The first one was that one of the reasons why scientists are often very wary of doing this is they think that the patients will just say, we only want innovations that are going to make a difference right now. We're not interested in the basic discovery science. We want things that are going to lead to a medicine in the next 2 years. And that wasn't true at all. They actually were very aware that it was the upstream basic science that particularly the charities involved had a responsibility to do, and that the condition would never be understood and hence treated more effectively if you didn't do that. So that was the first thing. But the second thing was that the research questions that the scientists thought patients want answered were all about pain. And pain was very important, but the joint stability was argued by the patients in this study to be just as important as pain. And nobody was researching joint stability. So that has had a very interesting direct impact on the direction in which that particular charity is taking its research strand. You can apply this, I think, to a lot of things. This is one of the big priorities that Wellcome has in our public engagement program. We want to encourage all the researchers we fund to put engaging with patients at the heart of the research questions that they ask. The other thing, which I suspect is something that Len will talk more about, is patient-reported outcomes in research, and how those can, particularly for chronic disease, be very, very important as well. I think that's probably enough from me from now, but on we go. Thank you.
Sure, of course.
And one thing also, you say how much time treating people with different conditions take to the system. And I say, and how much time it takes to the patient when you are treated by the system, like if you were only diseases and not one person, because of what we talked before, like going to different places and like, I'm not the disease, I'm a person, and which this society considers that you are valued if you are productive. So if you have to be going through the whole system because you have different diseases, like you're worthless. It's like the undergoing message from society to one that it's sick. So it's very important what you are addressing in research.
Len, please.
I'm borrowing Cecilia's microphone. The organizers took mine. I think they're trying to tell me something. So I wanted to just note, Cecilia, you made the point also that some of these insights we've known for some time, that applying human-centered design would really, and putting the patient at the center, would really bring some improvements, or at least address a lot of issues that we've encountered in the healthcare system. I think in some cases we've actually made things worse. In healthcare, we'll sometimes throw technology at the problem, and we are big advocates of the use of technology, but it's technology combined with behavior science, combined with human-centered design to develop solutions that recognize a pathway that really is more likely to get to a positive outcome and a positive experience for the patient. Some of those questions you raised when you were talking about, you go to the doctor and you're wondering, you're thinking about how you feel and what's going on in your life. Those have little to do with the actual condition. Like we all know there's plenty of research around socioeconomic determinants of health. We know that there are a lot of things going on in patients' lives that affect their likelihood to be adherent to their medication, to come back to the doctor, to test themselves, to eat right, to do all the things that we know that they need to do, and we tell them to do, but then we kind of act surprised when they don't comply with the right regimen. And again, I think we have to be very thoughtful as we think about patients' experiences through the whole system. Put them at the center, as we have in some examples, and not just immediately throw technology and think that technology is going to be the answer.
I'd like to bring Nick into the conversation with your vast experience in public service, obviously. What do you feel is most important? How can we get the system to be more, well, person-centered?
Well, I think the first thing to say is, of course, that it's unavoidable in some sense and inevitable that there will be a tension between what people think and feel as human beings who are ill, because that instills very, very powerful emotions of fear, uncertainty about the future, and those emotions then collide with a system which is normally big, because health systems have to be big because they have to deal with everything from a child's broken toe to serious complex cancers, therefore are often quite bureaucratic and managerially complex, and then crucially, in which hierarchy is dependent on specialization. So the higher you go, the more senior clinicians you meet, the less inclined they are to treat you as a human being, because they're either an oncologist or endocrinologist or this or this. So I think it's kind of inevitable in all societies that when you're dealing with so many different walks of life, so many different illnesses, such powerful emotions, and a system which drives reward and hierarchy according to narrowness of expertise rather than breadth of care, that you will get these tensions. I think, thankfully, there are there's a lot of evidence, and all of you on this panel know better than I do, there are some low-hanging fruit, there are some easy wins. I saw this myself. One of Miriam and I, we've got 3 kids. My oldest boy recently had lymphoma cancer. He's thankfully now recovering, but he was treated in a relatively newly developed teenage cancer unit in London. What was so special about that teenage cancer? At the end of the day, what was so special about it was there were only teenagers with sort of teenage decorations, but it made a tremendous difference. A teenager doesn't want to lie next to an 8-year-old, or even worse from a teenager's point of view, an 8-year-old. And so I think there are a lot of what you could perhaps call superficial, but nonetheless tremendously important things about the amount of information provided and the language used and the physical setting and the location of the different departments. I think there's a lot that can be done to make patients feel more comfortable, treated quite simply more as human beings. However, I think the thing that is really, really, really difficult to crack is this tension between specialization and the links between. We all know, don't we? We all know that there's intimate links between mental health and physical health. Yet I don't know of a single health system anywhere in the world. We all talk about it endlessly. I'm sure many of us have attended infinite number of seminars with the titles about integrating healthcare and physical health and mental health. We talk about it all the time. We don't really do it. No one's really managed it, I don't think, as far as I can see. So I think this tension between the balkanization of specialism, clinical specialism, with the fact that we are flesh and blood human beings who feel and think and experience things on so many different emotional, spiritual, intellectual and physical levels. That's the really, I don't know, I've got no answer to that, but I think we're at least starting to frame the problem more intelligently, not least because of the work of Cecilia and others over many years than we used to.
No, I think the reason that this challenge or this problem keeps going on, I mean, even at last year's, we talked about this, Cecilia, even at last year's health forum, and even at the OECD forum last year, we talked about integration, a holistic approach, and even medical professionals, they admit that we need a more holistic approach, a more human approach, more person-centered approach, but getting to that point is the difficult part. And with so many stakeholders in healthcare, in society, how can we go about doing this? Len, could you?
Well, just a thought. First of all, I agree with all of that, and even for patients that aren't suffering from like a clinical depression or other mental illness, we know that engaging patients and trying to find the right ways to motivate them and encourage them in the right way to be compliant, to come back, to treat their disease, to do all the things that we know they need to do, that's often not tended to. And for the same reasons that we've been discussing, the system is oftentimes pretty hardwired against that. I think there are a couple of thoughts. One is, I mean, all of these discussions are really helpful in terms of shifting mindset. You mentioned that we've been to a lot of events like this. Arguably, we need more events like this. We need more people engaged in this topic to get the mindset shift. And then I think we need to be co-creating. We need to be collaborating around solutions with that mindset, with that formula that says it's technology plus behavior science plus human-centered design wrapped around whatever the particular clinical issues or clinical outcomes that we're going after. Again, those are things that we've done on a small scale here or there. We just need to do on a larger scale.
Yeah, sure.
And one obvious sort of footnote and warning, which is that as we progress these discussions and as public policy becomes more intelligent and as systems become more human-centered, we mustn't forget, of course, that particularly where technology is involved, and technology quite rightly and thankfully is going to become an ever greater assistant and factor in the way in which we treat illness, inevitably the young and those who are both better off and better physically are going to be more adept and self-confident at understanding those interactions with a more technology centric health system than the old and those who are more vulnerable. And I think, you know, as we progress in one part of the sort of system, we mustn't forget that it's always the old, the frail, and the vulnerable, and particularly those who are not comfortable around technology, who will be in a sense, the first who deserve the greatest help, but will be the hardest to reach and the hardest to comfort.
That's a terrific point. If I can add on one application of technology, aside from all the great digital tools that people have access to as consumers and patients, there's technology applied within the health system that has yielded, I talked before about some of the kind of hard wiring, it's kind of yielded some of these experiences where you walk into a doctor's office and find that the doctor's not looking you in the eye so much, or the nurse practitioner, or another caregiver. They're not able to look you in the eye and understand some of these things that Cecilia is raising, because they've got to get the right information in the electronic medical record, or they've got to make sure for billing purposes they've got the right data, or they're following a clinical pathway that's being driven to them by the system in front of them. If we just keep doing that in the same way, we're going to get the same results, clearly.
I heard you say, Len, somewhere that technology is just not enough. I think this is what you meant by that. But in some cases, and Cecilia, you shared your experience at last year's forum also. Going back to that, could you share with us what you went through, with technology in taking care of yourself and your illness?
I have one story that pretty much shows what's dealing with a chronic disease and sometimes technology thinking somewhere else. I have a good friend that came to me once telling me, you have to take a lot of medication with rheumatoid arthritis, like lots of pills. Some days it's like, 15. So he came and I was struggling and dealing, how could I remember all this? And he came with this great solution. And he said, I have a digital pill case, and it will remind you every day, every time you need to take a pill. Isn't this great? And I was like, no, this is the worst. And he was like, why? I thought you would love it. I thought this was so for you. You need to. I was like, yes, I want to remember that I have to take my medication, but I don't want this telling me every day and like 3 times a day, you are sick. I'm going to live, I don't know, I hope, 40 more years with this condition. I don't want to be sick for 40 years. I want to be a normal person that has one condition that has to deal with it. And it has made my life change in some things, some important things, others that are not so important, like not having fancy shoes. But I want to keep my regular life as regular as possible. So I rather use other mechanisms, like take it, what do you do every day for breakfast? This pattern. Okay, so I will put the breakfast pill in this place so that I can learn how to remember and that, but not being sick every day. So that's something that technology, for example, needs to learn. And that's why I think solutions need to be made with patients and not thinking about what they need. Because they thought about what I needed, but they never asked me how I felt about taking medication every day. So we need to work more together. And in that, like 2 mental notes that I have, I think that we miss, like if this was a puzzle, we are missing one piece, that it's that we live almost all my time, I'm out of the system. I do not spend so much time in the hospital, in the primary health facility, near a physician, as I think the system thinks I spend. Because every solution is made in the system. But all the time I'm at my house, with my friends, with my family, at the park. How can we create health solutions out of the health system for chronic people? That's one issue. And the other one is that I really think also that patients' organizations have been doing a great work on the last years, like advocating for this, but we need also to learn, and that's something that I believe many people can help, and we were talking about this before. When you talk to a patient, many times we are frustrated, we have fear, even rage. So it's not easy to co-create with rage, with fear, with frustration. So how can we patients transform our stories, our patient experience, to a mobilizing experience? So that all the people or all the stakeholders or the creatives and innovators want my story and they want to talk to me and they want to co-create with me. And not only like, oh, here she comes again with all these problems that we don't want to hear anymore. So I think there's also something important that we need to do is that have more patients co-creating, having more patients mobilizing other patients. And I believe there's a lot of still road that we can walk.
Right. So much technology, it's just, sometimes you forget to put the human aspect, the most important part, into that. Mark, I know that you actually moderated a session at the World Economic Forum on 3D printing of drugs. I mean, it sounds a bit sci-fi and frankly quite controversial. Would you share with us some stories about that?
Oh gosh, if I can remember. It was some time ago that. I believe that the impetus behind that was really to think through the issues that, well, probably not that far away, that actually you would be able to fill a prescription that where you would be able to then put the active ingredients together, perhaps not in your home, but in a pharmacy or something like that, to make it very much more individualized. I think, though, that some of the issues that cut across this, coming back to what Nick was saying about specialization, is really important, because you don't just see it at the sharp end of the kind of patient, the patient in the surgery, in the waiting room, being seen by the medical professional. You also see it upstream when you get to the questions of research and kind of the questions of sort of trying to understand what's driving a condition and what you might do about it. And that's particularly true in some disciplines. One area that we're thinking a lot about at the moment is mental health. And one of the challenges, I mean, there have been no good new interventions for mental health for some time now. Most of the drug companies have checked out because there haven't been good intervention. There have been a lot of failures, a lot of expensive failures. The talking therapies, the psychological therapies, do seem to work, but we don't know how. We don't know what the biological mechanism behind cognitive behavioral therapy or whatever is. And you have, in some ways, a kind of sort of turf war between psychiatrists and neuroscientists, as it were, who barely talk to each other about what's going on here. And from the patient perspective, that's madness. It makes no sense at all. Contrast with cancer, where actually they've done this rather well, and there's probably a lot to learn from cancer in the way that professional disciplines approach things, where actually both at the clinical end, where you've got the nursing, the counselling, the actual specialist care are very integrated now in most health systems. Or at the research end, where if you speak to a basic cell biologist who's trying to understand what makes cells divide abnormally, or a clinical oncologist who's putting patients onto clinical trials and treating them, you ask both of those people what they do, and they'll say, I'm a cancer researcher, even though one of them goes nowhere near a patient and one of them goes nowhere near molecular work. You ask people working in mental health what they do, they won't say, I'm a mental health scientist. They'll say, I'm a psychiatrist, or I'm a clinical psychologist, or I'm a neuroscientist, and possibly even, I'm exaggerating slightly here, regard the other groups as a little bit the enemy and as competition for funds and resources and so on. And the patient doesn't care. The patient just wants something that works. And I think that's a really important lesson for science that patient involvement can start to teach as well. And I think that's something we need to establish. I mean, I've been talking about it for mental health, but I don't doubt it exists for many other conditions as well.
Actually, I think we had a question on the screen that was directed, well, I would like to think that it was directed at Nick. Could we have the question back on? It was the first one about UK citizens. I believe somebody from the UK asked that question. Could we have somebody from the forum? Yeah. Great. Technology. Thank you. Okay. All right. How will it be possible to provide quality healthcare services to UK citizens now that the NHS has experienced so many drastic cuts? Nick.
Well, it's not just the UK. Across the developed world, you just have an almost insoluble problem, which is that as we live longer, we have an increasing number of elderly folk with long-term conditions spending a huge amount of time in hospital. And the UK is not atypical in the sense that we had a hospital system designed for a different society, a society in which people went into hospital to get better and leave again. We're now using hospitals to house people, bluntly, for long periods of time. And that's the underlying problem. It's not budgets come and go, and post-2008, across the developed world, all health systems have been under financial pressure, many other financial systems under far greater pressure than the NHS. But that will wax and wane. The thing that we haven't cracked is that we've literally, physically designed a hospital system for a population that no longer exists, where we were dying younger, and we tended to go in for interventions and then be sort of spat out the other end. And so one of the reasons I got involved with the company that you mentioned earlier, Sarah, is that one of the things it's trying to do is to use technology precisely to prevent old people receiving domiciliary care, social care in their homes, from ending up in hospital, which is what's happening in our ageing society across the piece. So again, we talked earlier about integration of physical and mental health. Equally, integration of healthcare and social care for an aging population is self-evidently one of the sort of holy grails of health policy. And in a sense, I mean, I say this for sort of dramatic effect, but you can increase budgets for health systems as much as you like. If you don't find a way of stopping this kind of conveyor belt of elderly folk not being provided with adequate social care, and in their community or in their home, ending up in hospital beds instead, you're just going to be running to stand still all the time. And the UK went through times where it had sort of 4, 5, 6, sometimes 7% increases in health spending, down to our post-2008 down to sort of 1%. Increased, but increased much less. Now there's a great deal of pressure, rightly, to ramp it up again. That will go up and down, but it'll never solve the underlying demographic issue and the failure, certainly in the United Kingdom. I can't speak with similar expertise for France and other developed countries, but my impression is, a bit like the lack of integration between mental health and physical health, the lack of integration between social care, particularly domiciliary social care, and health systems is a systemic problem, which we shouldn't blame ourselves about too much, because it's a problem which has crept up on us with the change of demographics over the last 20, 30 years.
I think this issue about comorbidities is very important in this as well, because they do take up, so this is people who have more than one, particularly chronic illness at the same time, where that does also take up a great deal of a resource and put a great deal of pressure on the system, and is also often being funneled through, as Nick said, a system that was designed for other things, where people were presenting with largely one thing that they would get better from or die of, frankly. And so in the UK, we have our 10-minute general practitioner consultation, family doctor consultation. I was speaking this morning to somebody from the Netherlands who said it was really rather similar there, that you see this generalist first. And actually, in those situations, that 10-minute consultation may be fine if you've just got one thing wrong with you. But if you've got a list, and believe me, some patients do have a list, it's a terrible way of managing that presentation, and there would be enormous value in maybe piloting systems where, for those more complex patients, the GP saw that patient for much longer. There's a high chance that might actually save money, because you manage that condition more successfully, and therefore you don't get the repeat and ongoing cost of a poorly managed condition. So I think there are a lot of bits of innovation that could happen there. I can see Len's got something to say as well.
Yes, Len, please.
We were just joking about the mic on the side, I'm sorry. So the comorbidities, hugely important, these sort of onset of chronic conditions that then work their way through the system. I sort of see that volume coming through. We haven't talked at all on this panel, it's perhaps another day, about prevention. You know, a lot of these same healthy behaviors that we talk about are behaviors that if we can get consumers to act on, prevent some of these things from sort of coming into the system, these issues from coming into the system in the form of patients with complex set of conditions, complex needs that were, even in those situations, kind of ill-equipped to address. So I would encourage everyone to get your body composition measured around the corner, and if you uncover anything of interest, to do your best to act on it.
Wonderful. Okay, I'm going to go with another question from our audience. Could an AI solution that analyzes real-world evidence from patients be used to regain the client-centric perspective? Anyone like to tackle that one? Nick, perhaps?
Well, I think we need to be a little careful about the claims that are sometimes made about what AI means. It's a sort of two-letter thing which is now being bandied around everywhere. It seems to me, from what little I understand, and I'm not an AI expert, is that AI has this astonishing capacity to examine huge amounts of data and then pick out patterns. You know, it's why the earliest and most spectacular advances in the application of AI are in diagnostics. So there's now, you know, a lot of evidence that for certain cancers, skin cancers, for instance, an AI can examine thousands of different manifestations, skin manifestations, and just discern patterns much more rapidly and at volume in a way that that even the most expert clinical eye cannot. So I think we're going to see huge leaps and bounds in diagnostics, which is a wonderful, wonderful thing. Does that in and of itself make the person who's ill feel that they're treated better like a human being? I'm not so sure. It'd be a great irony if we decide that the way to make us feel more human is to resort to machines. I suspect the way that we like to feel more human is to be treated as humans by other humans. And just on that, can I say one final thing? The more I've listened to this, the more I'm interested in the parallels in other areas of public policy. In criminal justice, for instance, we know, and there's a lot of evidence, that prisoners who are in prison for a long period of time and develop a relationship, particularly with enlightened leaderships of prison, are those who you can work with to reduce the likelihood of reoffending. So those who come into the prison system for the shortest period of time almost always have the highest rates of reoffending, because you can't do very much with someone who just comes into prison. Now, similarly in the school system, the best class teachers, the best head teachers, provide what is called now a child-centered education. They don't just look at the marks. They don't just ask, are they good at biology, are they good at chemistry, are they good at history. They look at the child as a whole, and they treat the child as a whole. The great problem in health is that we're asking clinicians to treat millions of us as humans, even though for the vast majority of us, they only have a fleeting association with us. We travel through the health, some of us don't, but we travel through the health system, like sort of shooting stars. It's incredibly difficult to expect a system to take a snapshot of somebody at a snapshot moment in their life when they have a particular illness at that particular moment and treat them wholly. So I just think we need to, again, I feel some sympathy for clinicians who are expected to, a bit like the prison governor who's expected to do something with a young offender who's come in just for a few months. Really, really difficult to develop the human relationship, which, by the way, I don't think any AI machine can necessarily duplicate.
Can I just a quick addition on the AI point? So agree completely on your assessment. I would also suggest that some of what we want to learn and be taught through adaptive engines and intelligence embedded in systems requires data that we often don't collect. Right. So it's only the AI tools and capabilities are really only as good as the guidance that they get and the data that they're fed. So if we're trying to find reasons why one person is compliant, another is not, or why one person gets to a better outcome, perhaps driven by behaviors earlier on in their experience with a given condition, we're not going to learn anything from AI if we don't provide the data. So something to think about as we're investing in AI.
Cecilia.
Yes, that when we think about AI and we imagine really big solutions, I want to give one example. My sister has the same condition that I have. She spends every month 6 hours at the hospitals because in one place she can pick the hour, she can ask for the appointment for the next month with the doctor in one place. So she has to be sitting there, waiting on a line, and then she has the appointment. Then she has to walk to another place to get her biological medication. And there she needs to spend like 45 minutes more on a line. And then she walks to another place of the hospital to get her the common drugs. She waits like 45 minutes to just the paper, give the paper. And then she spends like 2 hours for the whole prescription to receive it. She's a physical education teacher, she teaches, she's active. So more than all this big data, and we really need to ask people and talk to people and be sitting on this line, but not for once, because maybe for once you get some ideas. But if it's not fair, I feel I can tell her story, I'm allowed to tell her story, but it's not fair that she needs to tell the world that she has this condition. Because if she has to spend 6 hours every month, and that it's not counting that she needs to go to the rheumatologist, go to the physiotherapist, all the rest, she can't have a normal and a regular life because she needs, for example, to tell her boss that she is sick. She shouldn't. But the system is designed for acute diseases, not for chronic diseases. We are advocating with the government, why couldn't chronic patients get the whole prescription from the primary health facility? It's a prescription that it's 6 months. You will be taking the same, the majority. Why medication is not sent to the health care facility near to your house, that you can pick it on Sunday or on Saturday? So it's about caring for the other, and it's not putting like patients, like it's not about clinicians. Clinicians, I believe, and I know because we have talked about it, they struggle with the same issues, that they cannot take good care of their patients because they need to be filling all these papers and the computer and ta-ta-ta. So it's about rethinking the system. I really believe that, for example, I say the word adherence. Adherence is the way the system wants to make the patients feel guilty about what the system cannot give. Because if you have to spend, yes, and if you have to spend 6 hours to have your prescription, really, it's my fault not being adherent? Like, it's not. It's living with a condition, it's work enough. Like what we ask, let's think a system that doesn't make us work even more in taking care of yourself.
Excellent point. And I'd like to point out that if we don't have anybody from the medical profession on our panel, but if you are in that and you'd like to state some facts or state otherwise, I mean, please do join in through this BCast. And it's not just for questions, it's for comments also, so keep that in mind. Okay, I'm going to go with another question from Jake Stevens. He's about the only one that used his real name here. Has the implementation of quality methodologies been applied appropriately to healthcare specifically the way metrics are determined and how those metrics are quantified. There's some difficult questions here. Anyone wish to tackle that one? No, it's too difficult for these people. You want to take about that one?
Well, I have a microphone. I'm happy to talk about it for a second. You know, I think it's a question of what gets measured. Like one of you know, we're implementing in the U.S. quite a number of you know, quality measures, and the thing that that I like to see in the implementation of measures and the application of process improvement is this focus on patient. It's the quality measures in the family of patient satisfaction and experience. So I'll just make a general comment that you know, to the extent we are rethinking, you know, what to measure, rethinking process, if we keep the patient at the center and include that in the measurement, we will get what we measure. And if that's patient satisfaction, we'll move the needle.
I've been told that we have 15 minutes left. I'm going to invite Francesca, it's okay, to share with us her thoughts. As I said, she's been watching over us during the whole discussion. So please, Francesca.
Yes, thank you. Thank you very much. I mean, this has been really fascinating. As you mentioned, it resonates a little bit with some of the discussion that we had about just over a year ago here at the OECD. We had a meeting of health ministers about the next generation of health reforms, and the day before we had a panel discussion, the forum, which was about people at the center, the future of health. So in a way, we are rehearsing some of these discussions that came in there. The consideration the ministers had that also gave some mandates to OECD was pretty much the starting point that you made. You know, health systems somehow are struggling to keep up with the new demands due to aging populations, pressure on costs. You know, obviously the financial crisis is over now, but the pressure is there. We cannot really assume they will be able to sustain health spending growth at the level that it was before the crisis. And therefore, all of these call into questions whether what we deliver in health systems are really making a difference. So health ministers really asked OECD for help. They are for help in how do we redesign health system, which is really what is being discussed here. How can we re-put people at the center? But what policies need to be put in place? Do we focus on things like literacy, for example? It's not really been mentioned here, but we hear quite a lot about that. How do we think about technologies and assessment of technologies? Which technologies really make a difference? How do we incorporate them into health systems? Even how do we price them in a way? How do we get rid of waste in health system? We have done some estimates which are about 20% of health system being actually not delivering any added value for the patients. So I guess the first consideration in terms of our future work, we are now thinking at OECD about a framework for people-centered health systems, and trying to populate that framework with what are the policies. Perhaps how do we change some of the policies, the payments policies, the health workforce training policies, and so forth, in a way that really we can make progress towards people-centeredness. So, you know, walk the talk in a way. And perhaps I would also be interested, from your perspective, what would be perhaps the #1 policy that you would pick up and you would like OECD to investigate more, because that has been forgotten, because perhaps we have a health system that are geared towards an individual illness and not about the multimorbidity that we have been talking about. So that's my first point. That's what we are doing, and I'm interested also to know your thought, because it's going to help our future work. And the second point is about how do we measure progress, of course, because talking about people-centeredness, I mean, it has been going around for quite some time. It's not a concept which is entirely new. And in a way, you know, it can be sometimes disappointing about keeping on talking about that, but not really being able to say whether we're making a difference or not. So at OECD, what we're doing is that we have launched a big initiative called the Paris Initiative. It's a patient-reported indicator surveys initiative that really looks at indicators of experiences and outcomes from the patient's perspective. So again, I'm interested to know, also what the views of the panel and of the audience about that. Are we right now measuring the right things in healthcare? How do we then combine these new metrics that we hope to collect with some of the more traditional metrics that we're collecting? So, just a few thoughts. I think it's a great discussion. I'm interested perhaps into the way forward, also way forward for us at OECD in terms of policy issues that we may want to analyze and look at. Anything we have not done as yet that you would suggest. And then, obviously this measurement initiative that we have that is for us quite particularly important is a missing link at the moment in what we measure in health systems. So your thought also on that would be quite useful. So
Thank you very much, Francesca. We do have high hopes for that new Paris initiative because, as I said before, cure and survival rates, that is not enough to measure healthcare success. I'm going to now open the floor to questions. So if you have any, please raise your hand and a microphone will be brought to you. Yes, the gentleman on the left, please.
Thank you very much. A fantastic discussion in the panel. I wanted to pick up, well, there are two testimonies at least on the panel where one a very direct one suffering and one an indirect one, Nick with his son. I've been in an indirect position as Nick has in recent times as well in terms of someone very close to me suffering. And I'm wondering, as I was listening to you all, do you think one of the policy decisions that could be made, and it's quite a simple one, it's adding a criteria to the designation of people in certain positions. Would it make sense in today's day and age where many people have survived through good healthcare, better healthcare, but have also learnt from those experiences, to make it a condition that if you're going to become a health minister, you have a direct experience of what it is to go through the health system, for example, as a patient of a serious disease, a chronic disease, not someone who's broken their toe. Would it make sense for the person at the top of a major pharmaceutical company or health company have a similar type of experience? Would it make sense for someone very influential in a foundation like the Wellcome Trust to have that direct experience? Would it make sense for someone who is reporting in the media on health to have had that personal experience? There's another panel going on in another room right now, and we have a sports minister, and she has won a number of medals in fencing. And so in sports, it's very traditional for people to put in sportsmen and women into those positions. And I'm just wondering if it would make sense to actually put people who've been in those situations. To really push the envelope, it would say, well, could you have a former prisoner as a Minister of Justice? I know that might be a bridge too far.
Nick, would you like to add to that?
In short, no. Not because it's a bad idea to have folk in positions of authority or influence with direct experience of the areas over which they have authority and influence. It's just that what little I've observed is that given illnesses come in so many shapes and sizes, as do sports, indeed, as do prisoners, indeed, oddly enough, what you sometimes can get, not always, is that someone who has a particular burning mission to deal with something which they have personally or indirectly through a loved one experienced, it actually can be as much of a danger to them exercising objective judgment as it is an assistance in doing so. And so, great if it kind of, the cookie crumbles in a way that, in your example, a sports minister so happens to have a great deal of experience of sports as well. I remember in my time in government appointing someone as a pensions minister who thankfully knew more about pensions than most pensions experts put together. It was a great support and a great benefit. But I think to make it, which I think you're implying, almost a requirement that you have a personal experience, I would be very, very wary of that, because you want, in all decision makers and anyone who exerts influence and authority, yes, you want people to be able to have empathy and insight, but you also want people to be able to act objectively. And it's, oddly enough, sometimes harder to do that if you are, quite understandably, we're all human, heavily influenced by your own experiences. Though, can I just, as a small sort of footnote, add something which I thought you were going to go on to say, but might be of some interest if I were just to say it anyway, which is that one of the experiences that I felt, and I'm sure you felt the same, or feel the same, is the importance to not only treat the person who's ill as a human being, but crucially their family as well. And I think one of the things that we're all learning as clinicians, not as clinicians, sorry, the clinicians are learning, is that actually you can't, firstly, you can't treat someone who's ill just through the narrow lens of whatever condition they've got. You've got to look at them holistically, but you've also got to look at their family context. So one of the things I've learned through the work that I do with this technology-enabled social care company, Sera, is that the information that you gather through technology of the state of mind and the well-being and the health of an elderly person receiving care in their home is not only valuable to them, it's not only immensely valuable to the carer, who can then try and anticipate their health needs, it's of huge emotional value beyond everything else for the sons and the daughters. We have a whole sandwich generation of people who are often having to look after children on the one hand and elderly parents on the other, and to receive through technology an update and more information about how their elderly mum or dad is doing, I think is a huge, huge boon. So I think we're not just talking about treating one person as a holistic individual, we have to treat, in a sense, their own community as well.
Cecilia, you'd like to say something?
Yeah, but now I want to say another thing. Yeah, like the biggest struggles, the biggest fights that I have had with my partner is because him trying to help me not to carry weight. It's as simple as this. Like supermarket bags, him getting everything and saying me, you don't do anything, and me feeling like I'm being left apart, and I'm like, hey, I still can do my own stuff. And that tiny, tiny, tiny issue has become the biggest issue in our relationship when it comes to be on a bad situation. And he really deals very good with my condition. But even though like it's a big thing to learn, the family to learn how to deal with all this stuff. And as a patient, I would say, and now to the question, no. I really think it's good that they have had an experience maybe, but the role is different. But what I really think it's missing is to partnership better. I don't want the minister to be thinking as a patient all the time, but I want him really to be listening more to the patients. And that's something that I think it doesn't happen. I don't want the innovators, I want them thinking more with patients. The funding patient initiatives more. Because we do have questions for research. We do have ideas for technological support for patients that we have ourselves designed, questions that we want to be answered. We have what's needed, but we need better partnerships.
If I could just add, I would also agree that you wouldn't want that to be a requirement in any ways. I think you only have to look, certainly in the UK, at education policy and how that has been bedeviled by the individual experiences of particular people who've been to a certain kind of school and therefore think that's the best way to teach everybody, to see how damaging that could potentially be, I think. But I think what you've just said, Cecilia, is a really important point, that you don't, I think you can build on what you were saying and say, actually, there are other ways to get that perspective into the conversation, because it absolutely must be part of a conversation. And I think it's great that OECD are developing these indicators. The one plea I would have from my organisation's perspective is, please include research. Please make sure that you're including patient involvement, public involvement, because, of course, it's not just patients, people who are not patients yet have just as valuable an input to make into all of this should really be included within this as well. At Wellcome, one of the things we're doing that's a very exciting initiative, we're launching next year something called the Wellcome Global Monitor, which is a international survey which we're doing with Gallup of 140,000 people will take part in measuring public engagement in science. And one of the things that there'll be 140 countries involved in that. It would be interesting to have a conversation about whether that may be useful to you in any way, because I think one of the things we could do through that is to look at the level to which public feel engaged in the research direction in particular countries. So I think there's a lot of opportunity for doing this better. Indicators are vital.
I do wish that we had more time for more questions from the audience, but we're told that time's up. But we did lose some time at the beginning to our former panel, so maybe one more question? No? We'll just take one more short question. Okay.
Hello. Thank you very much for this very interesting panel. I just had a question. You did mention at one point artificial intelligence and whether this could be a solution to improve health and well-being. I was wondering if any of you, or if it'd be possible in terms of public and private partnerships, to do something with patient data in terms of, because I mean, we're talking about data constantly, and I'm sure that in some areas to advance research in health and in diagnosis and everything, there could be at some point a collection of data that would be anonymous in terms of patients to try to establish more links between what you were talking about in terms of the holistic approach, in terms of what's being affected in terms of mental health and physical health, and if this is something that at one point could be considered in public policy.
Can I just speak for, speaking for J&J, we are extremely interested in that topic. So if you want to talk more about some of those opportunities, like outside the session, chase me down and I'd be happy to discuss it.
So likewise, I think I'm glad you've asked that question, because I think there's huge opportunity there for this issue and indeed many other issues where the aggregation, it's not about the individual patient there, it's about the aggregation of patient experience and spotting patterns, as Nick was talking about earlier. I think there's a lot of potential in that, but if I may just add one caveat, it's vital that we do that in a responsible way that goes with the grain of public acceptance, rather than it being something that is imposed. Because I think if it's imposed in a way that isn't sensitive to the very emotional way in which people quite rightly often react to data about their own health being shared, we have seen, just as we've seen in the past few months with Facebook and Cambridge Analytica and so forth, there is a real danger that if we don't get this right, then the potential of it may be stillborn, and that would be disastrous.
Thank you so much for that question and the answers. You'll follow up with the question after the session, I believe. Well, on that note, we will wrap up this session. Thank you all for participating. Thank you for being such a great audience. And let's have another round of applause for our panel. Thank you very much.
Very nice meeting you. It was so great to hear your story, both on the conference call and separately. So, please. Yes. Okay. Okay. Call me. Do you have my card? I mean, I know you have it in the system. I have my email on it. Okay. Great. Excellent. Okay. That sounds terrific. Pleasure. Thank you.
Thank you.
Thank you very much. Oh, were you?
I'm very sorry.
No, that's okay.
Yes.
No, we're not about it, I'm afraid. Hi, were you just after that data? Yeah. We do. Oh, it was such a pleasure. Thank you. Nice meeting you.
Your email.
What's that?
I have your email.
From analytics, we have these massive analytics using AI, just specialized in pharmaceutical
Non, normalement, c'est que là, c'est bien reçu.